This is a brief introduction into an exciting new field in prostate cancer and radionuclide therapy, and that is 177 lutetium-based PSMA therapy for metastatic prostate cancer. So I'd just like to introduce this concept of theranostics, which is a combination of the word therapy and diagnosis, and is now increasingly used to refer to this exciting new field. Theranostics utilizes specific molecular targeting for the combined purpose of therapy and diagnostic imaging. Usually this approach uses the same molecular target on a cell that is bound to a radionuclide, becoming the radioligand. So for example, iodine-131 and lutetium-177, which are both gamma and beta emitters, can be used for both imaging and therapy. Critically, imaging the potential target helps predict if the radioligand will be beneficial and how much radionuclide will be necessary for safe dosage and therapy. Nuclear molecular imaging utilizes two basic approaches. The first are gamma emitters, and as we know, these are the most commonly used agents. For example, 99M technetium for bone scans, and also positron emission, which, as we know, is most commonly used in PET-CT with fluorine-18 based FDG and PSMA. Radionuclide for therapy in cancer requires killing the cancer cells. The local penetration of tissues depends on the energy of the isotope that we're using. Usually the type of decay will provides either beta emission with lutetium-177, for example, or alpha emission with actinium-255, which is also a new emerging agent. It's important to note that radionuclide therapy has been around since 1946 when it was first used for thyroid cancer. It is now also the cornerstone of multimodality therapy for neuroendocrine tumors, where it is referred to as PRRT. PSMA is expressed on the surface of prostate cancer cells. Importantly, its expression increases progressively in higher grade tumors, metastatic or hormone refractory disease, and also in patients that have undergone androgen deprivation therapy. The level of PSMA expression is a significant indicator for disease outcome. PSMA is not entirely prostate specific, as we know, but is also expressed physiologically within salivary and lacrimal glands, the kidneys, and the small intestine. A variety of PSMA ligands for PET as well as SPECT-CT imaging have been introduced into the clinic over recent years. Majority of practices will use gallium-68-based PSMA tracers. However, we, in our practice, utilize 18F-based DCF-PYL, which was developed at Johns Hopkins University, and we believe it has a superior imaging qualities based on fluorine-18, and also for its ease of use in our clinical practice. And this is a slide here showing you the importance of PSMA expression for pathologists when they're diagnosing biopsies of previously unusually considered sites of metastatic disease, such as supraclavicular lymph nodes. And you can see here the exquisite PSMA staining on a lymph node that's been detected by PET-CT. Lutetium itself is a beta emitter, and it has favorable characteristics for radionuclide therapy. 177 lutetium PSMA binds rapidly to PSMA on prostate cancer cells and subsequently is internalized within the cell, where it remains dependent on its 6.7-day half-life. Lutetium-177 has a maximum tissue penetrance of approximately 2 mm, resulting in a crossfire effect in which adjacent cells that may express lower levels of PSMA are also effectively killed. Importantly, this short path length results in minimal radiation delivery to adjacent normal, non-diseased tissue. Lutetium-177 also emits gamma rays when it decays, and this therefore enables us to perform SPECT-CT imaging once administered to the patient, thereby enabling dosimetry and visualization of where the tracer has accumulated. And this therefore makes it the perfect agent for theranostics. The clinical role of lutetium-177 PSMA really lies in the fact that the major cause of death in prostate cancer is not early disease but resistant disease after first and second line medical therapies. And this is where it really has come to fore in recent years as patients who are progressively aged become resistant to these medical therapies. Utilizing an agent such as lutetium PSMA provides provides a potential advantage of symptomatic relief and perhaps prolonged survival. The patient that would be ideally suited for lutetium-177 PSMA therapy at this stage would be such a patient failing traditional therapies, and also with careful and judicial selection before before therapy is considered. Most importantly, we require high-level PSMA expressing metastatic burden, and also which is concordant with FDG uptake, and also patients who have stable hematological parameters and reasonable comorbidities. Lutetium-177 PSMA therapy is well tolerated, and the usual side effects are very mild and include dry mouth from lacrimal and salivary gland uptake of the radiotracer, fatigue and nausea. The potential risk of marrow suppression does exist. However, thrombocytopenia and significant neutropenia requiring hospitalization is seen in only in a minority of patients thus far. And although the kidneys receive the highest radiation dose, no relevant nephrotoxicity has been observed in patients so far. Now, importantly, Australia leads the field in this area of theranostics with a recently published phase 2 prospective trial in Lancet Oncology, led by Michael Hoffman's team at the Peter Mac Hospital. And they treated, and we've treated at the Peter Mac so far 30 patients prospectively, and we've seen approximately 2/3 of these patients achieving a significant PSA decline, but more important, the majority, over 80%, show an objective response to therapy on imaging, and clinically meaningful improvements in pain and quality of life scores are seen in the vast majority of treated patients. Toxicity that's been encountered has been very mild and mostly symptomatic, and only 4 patients have had significant thrombocytopenia. This data has now proved the foundation for a multi-center Australia-wide prospective randomized controlled study called a therapy trial, which will provide the solid data into lutetium PSMA therapy. And in the latest EJNM, which is the European Journal of Nuclear Medicine review, states the current available literature envisions that the theranostics of prostate cancer will be commonplace in the personalized cancer of men. I want to discuss 2 cases with you. The first is a case from the Peter MacCallum Cancer Centre, which shows you a patient with metastatic prostate cancer, including bone, nodal, highly PSMA expressing disease. And these are a series of SPECT CT bone scans, what we would normally see as bone scans, but with lutetium emitting gamma rays. We can see here that there's extensive uptake of radionuclide into the areas of PSMA disease expression, and subsequently we see a dramatic response to PSA levels, which at 36 weeks is mirrored by a repeat PET scan showing minimal PSMA uptake in those areas of disease. And in another group's published data, we see here in this case a case of much more extensive nodal and peritoneal disease, as well as multifocal bone disease, being successfully abolished essentially on imaging with 3 cycles of lutetium PSMA therapy. So we really are entering into a new field, and this is something that we're hoping to explore locally as well.